Good morning, everybody. Thank you for joining us for our complex pediatrics clinic today. How's everybody doing? If you guys want to actually start talking, you can go ahead and unmute yourself when you do want to speak, and then put yourself back on mute. That way we don't have excess static and stuff like that.
Okay, come when you're ready.
Can everybody hear us?
I can. This is Therese Black.
Hi, Ken. This is Carrie Randall.
Good afternoon. So I'm Kathy Eckert. We're going to be talking about caring for transgender youth today. If we can just take a second, if everybody can introduce themselves and tell me just a little background so I know where we're all coming from, that'd be great.
I'm Therese Black, and I teach pediatrics for Carrington College. I also have a transitioning nephew who was born female and is moving toward ma'am.
Okay, thank you.
I'm Carrie Randall. I'm an practitioner. I work with pediatrics and adults.
Great.
I am Natalie Vogel. I'm a pediatrician at Northern Nevada Hopes and the chief medical officer here. Can she hear me?
Yeah.
And Dr. O'Connor, I see you. Okay. Eileen? Anybody else want to go? All right, so a little bit about myself. I am a pediatric endocrinologist, and over the last 5 years or so, I have started to see more and more patients with gender dysphoria, transgender issues, and so on. So it's actually very rewarding for me to take care of these patients. And I have to say, I've learned a lot as I have managed these patients, gotten to know them on a very personal level, and probably more so on a personal level than most of my other patients, because clearly it's not just about medical issues. This is a deep-seated, psychological issues arise, and they are so willing to be open with me. Now, part of that, I think, is that by the time they've come to see me, they've been through so much. And so, they've already potentially come out to a lot of people, and so they're feeling a lot more comfortable, and I think that really enables me to have a better relationship with patients. So, but in many cases it's really not easy, and certainly it's not easy from the patient standpoint. So today I'm going to talk about sort of basics and definitions and so on, which may be old news for some of you, but I think it bears looking at and talking about. And also I think we all can understand that some of those definitions, some of those words are changing, and what they mean to me may be different than to you, and certainly to some of our patients. So I try to be as generic as possible, especially when I'm talking to young people. I think adults are a little bit different in terms of how we can talk to them and manage them and where they're coming from, okay? With all that said, please interrupt me if you have any questions at any time. Today, we're going to talk about kind of generalities and then some of the hormone treatments that I use and why and for how long and so on. We're going to have part 2 of transgender care in children and adolescents in September with Dr. Healy, who's a pediatric infectious disease person. So she'll be talking about PrEP and other issues related to infection and other issues associated with medical problems and gender dysphoria. Okay, your little preview. Okay, so I always like to start out with this because if you yourself have had a baby, or we're all in pediatrics on some level, so what is the first question that everybody has when they have a baby? What is it? Is it a boy or a girl? And still this is so striking in our society. I think we're making some gains and broadening our idea of what that means. And now some states are not even identifying at birth male versus female. You can click other on the birth certificate, for example. okay? But, you know, for the 99.5% of the population, I still think it's male versus female, and so much is loaded in that. From basically the moment you know you're pregnant, okay? That's what everybody asks the question. So I want to discuss how maybe we can get away from that a little bit, and certainly as kids get older, how those definitions change. So this is Christina Jorgensen. I'm just going to play a short little movie for you. She's a transgender female, and in the 1940s, she transitioned. She was a male in the military for many, many years, and then decided to transition. She was sort of the beginning of the sexual revolution in terms of transgender care and hormonal therapy, as well as ultimately surgery. Even though some doctors, which we'll talk about in a little bit, were going on as early as the 1920s about how this may be something that we really need to pay attention to. It really wasn't until Christina Jorgensen came out and very publicly that people were a little bit more accepting and knowledgeable about it. I'm gonna go ahead and play the movie.
I'm very happy to be back. I don't have this time to learn. Thank you all for coming. But I think it's too much. Fine. Thank you very much.
Hey, NBC News fans, thanks for checking out.
So what's always interesting to me is that that movie was taken in the 50s. She started transitioning in the 40s and came out, and clearly it was very publicly known. And here we are in 2018, and I think it's only really been the last 10 years that we've made any significant strides. So I guess I wasn't in tune with it enough in the latter part of the 20th century. But it really makes me wonder what was going on. You know, clearly there were still many people who were trying to transition. It's just that we really weren't taking very good care of them. So I hope that going forward we can do a better job, okay? I really like this quote from her as well. If you understand transgenders, then you understand that gender doesn't have to do with bed partners. It has to do with your identity. And I think that's where a lot of people still get mixed up outside of the medical community, perhaps. This has to do with being gay, or this is your preference, or this isn't something that you were born with, you know, this is just something you're making a choice about. And I think there's all kinds of things that go into people's decisions, but in working with kids who are generally true to the core, this is something that is there. And hopefully we can find out more about why it's happening and then learn better how we can manage it. Okay, so a couple things on some definitions. So gender conformity, you know, I think what that means to me is certainly different than some of you. And if you go to a different country, especially third world countries, that definition is extremely different. Our society, I still think, views gender conformity as binary. There's a male, there's a female. In some areas, we are getting better about that. In other countries, it's definitely not binary. And in fact, it's, you know, they worship people who are maybe transgender or somewhere along those lines. So somebody who was born as a male, but in adulthood is actually seen as a female. They're actually revered. the definition for different age groups is also different, you know, and I think today's kids probably see it much, much differently than we all did as children, and I'm hoping so. But bottom line is, it should be a continuum without strictly binary, and where you feel you are as a 5-year-old versus a 50-year-old may be completely different, and that's absolutely fine. And even within a day, in talking to some patients, how they feel what their gender is can be also completely different, okay? As I mentioned before, in 1923, Hirschfeld and Benjamin, who were two physicians, pioneered medical responses to patients who had what they called then gender identification issues or discomfort with them, which later became known as dysphoria. So back in the 20s, kind of hard to even imagine. So gender incongruence or nonconformity versus gender dysphoria. So incongruence is how a person's gender identity or their role or their expression differs from what most people feel are the cultural norms described for people of a particular sex/gender, okay? And so that can be different. It can also be coexisting with dysphoria, but it doesn't necessarily have to be. And what I really want to focus the most on, because the incongruence, again, varies so much from culture to culture, is dysphoria. And that's really the patients that I see. So they are uncomfortable with what they are identifying as or have been identified as from parents, from medical community, and so on, okay? And so they're at odds with how they feel internally versus what is on the outside. But importantly, I really try hard not to label. Now, I don't see adult patients, and so for adults, there may be other reasons that it is important to have a sex or no sex or gender or what have you. But in pediatrics, I really feel that it's important not to do that. I usually start our conversations with, you know, not who do you identify with, because what is a child supposed to say, but rather, what name would you like me to call you? And if they're old enough, what pronouns would you like me to call you? Okay, and it's not he and him, she and her exclusively. It can be they and them, or sometimes it's he and him, and sometimes it's they and them, okay? Now, this is confusing for us as medical providers. You know, we were trained, especially those of us who've been on this planet longer than 40 years, we have been trained it's male or female, and all that goes with that, right? Check the box. And even electronic medical records today, most of them do not have an alternative. We're working on that, and also on the birth certificates and so many other legal documents. But for right now, it's kind of ingrained, and I think it's a little difficult to get away from, sorry. But I'm trying my best, certainly. And, you know, imagine parents, too, who have raised this child who they deemed a boy at birth or even before, and now at 12 identifies as a female. And changes her name, and so it's very, very difficult for these families. So I have had the pleasure of going to one of the WPATH conferences, which was fantastic. If you ever have a chance, and if you're involved in care of transgender patients, I really encourage you strongly to go. It's the World Professional Association for Transgender Health. So one of the worldwide organizations that's really come together and helping to get consensus and guidelines for patients across the world. I mean, it doesn't happen very often that we are able to do that. They, in conjunction with the Endocrine Society and now the Pediatric Endocrine Society, we're all kind of getting together and developing clinical practice guidelines. So each of the WPATH and Endocrine Society have published their practice guidelines, and they're fairly general in nature in terms of hormonal replacement and so on. I think where it gets more difficult is the mental health piece. And of course there's definitions, which we'll get to, but they're rather dry and perhaps don't fit all of our patients. One thing that both of these societies are trying to do is to develop long-term assessments and outcomes, so that we really know, you know, what happens if we give a natal male estrogen for the next 65 years. What can we expect? You know, What are the effects on the brain? What are the effects on the heart, lungs, and so on? You know, we don't have those answers because going back far enough, there's just not enough numbers of patients to really do any long-term studies to evaluate that. That, and patients generally don't want to be viewed as subjects who are in a study, who are going to be looked at in a different manner, perhaps. Okay. So in the adolescent population, you know, what are the effects of delaying puberty? If we see these patients and start them on puberty blockers at Tanner stage 2, and we delay puberty for 5 years, what does that mean? And what does that do to your frontal lobe development and the rest of your brain, for that matter? What does that do to bone density? Does that help or hinder gender identification? Does it matter? Yeah, so many questions that arise. So a lot of this is still open. And then risk and benefits of, as I mentioned, you know, gender-affirming hormones, so mainly testosterone and estrogen, but even puberty blocker use in adults as well for extended periods of time. We need to follow those patients. So I'm going to switch now to primarily children. So interestingly, of those children who identify with gender dysphoria prior to adolescence or puberty onset, so let's just say less than 10 years of age, only about 15% of them go on to have persistent gender dysphoria. Now, that's a hard statistic to come by. I think all of our reporting types of data is certainly not representative of the actual population, okay? And more is needed to be done. So some of this data is probably now 5 years old, but very, very limited. So in those children referred for dysphoria, so that's yet a different category that they've come out and said to their parents, and then the parents say, oh, we need to get help. It's a very small population. The male to female ratio is between 3:1 and 6:1. So many more males than natal males than females are reporting dysphoria. By the time you hit adolescence, it's about 1:1 on the ratio. So the issue with prepubertal kids is, you know, what is their definition of what a girl is versus a boy? And it depends on the environment you grow up in, not just your parents, who may be 2 females or 2 males, but also just what social constraints bring upon all of us. So, you know, if you encourage your little girl to play with Tonka trucks, how does that change how they identify? I don't know. So the natal assignment varies with clothes and toys, games, peers. And then there's your discomfort or lack of discomfort with your genitalia. And that doesn't become a huge issue typically until adolescence, when all the changes start to happen. So in my practice, I will have young patients, as young as 6 or so, come in and say, you know, when I was 3, I decided I did not like my penis and I wanted it cut off. And I told my mommy I wanted it cut off. Well, what does that really mean? I mean, does that truly mean that he has gender dysphoria when you're 6? And so those kinds of kids, we really need to follow them and support them. I think that's the best thing we can do, support them, let them identify however they want to, the best way that we can possibly help to support them. These kids oftentimes have anxiety and depression as the presenting symptom or issue to any kind of health provider, mental health or otherwise. Anxiety and depression. In my practice, it's 100%, no doubt about it, if you're over the age of about probably 8. So definitely 100%. Usually that anxiety and depression gets better after we start treatment, or at least address it, and after they've come out and feel some support with that. Interestingly, the prevalence of autism is much higher also than the general population in the gender dysphoric population. Why that is, or what that relationship is not known. In my own population, I don't really see that. I have, I think, just 2 patients who have been identified as having autism as well. So while gender dysphoria incongruence may be the first sign, okay, that a child is destined to be transgender, it's certainly not 100%. Only 15% of that population actually remains dysphoric and identifies differently than their natal gender assignment. Okay, Many of those patients, though, who identify early on will later be identified as being homosexual or gay. When one has socially transitioned, this makes sense. When you've already socially transitioned, you have a much higher likelihood of persistence of that gender dysphoria. But I think there's a lot wrapped up into that. First, you may be more committed on one level to your dysphoria, and that's why you socially transition. But you can all imagine if you socially transition at school, at home, at church, wherever, at sports, it's going to be very difficult to go back to your original assignment. Very, very difficult. And that's one thing I worry about all the time. You know, what are we doing as healthcare providers? Once we start the gender-affirming hormones, you know, those are considered irreversible. So I think we have to have a lot of caution in when we do things and how we do them. And we'll talk more about that. So I don't necessarily believe in this last statement, but from the WPATH, this is what their thoughts are, that persistence of gender dysphoria can only be reliably assessed after the first signs of puberty. I think that many of these older children who are not yet in puberty have a very good sense of where they are. And even as young as 3, now that doesn't mean that's going to persist, but I think that many of them do have a very good sense of that. We don't start treatment typically until after the first signs of puberty because we want to see what happens during early stages of puberty. Sometimes it's affirming and sometimes it's like, oh no, this is okay, this is where I'm supposed to be. Okay, so again, this is one of those skewed pieces of data. Persistence into adulthood is 80 to 100% in those given puberty suppressing hormones. Well, yeah, kind of for the same reasons as social transitioning. You know, perhaps they were more committed, perhaps now they don't want to go back, and so they're going to continue with their persistence of being gender dysphoric. In the older age group, pubertal age and above, the ratio is about 1-to-1 in males and females. I always find this interesting that I would say most of the adolescents who come to see me, when they were children, their parents will attest as well that they were perfectly happy with their natal gender assignment. And it wasn't until closer to puberty that they began identifying differently, or even into puberty. Sometimes even long after puberty had ended, especially for natal females. Why those variations, that's not clear. So again, we see the depression, anxiety, oppositional defiant disorder, much more common in dysphoric adolescents. And when I'm talking to these adolescents, it's very interesting to me. I ask them, so, you know, when you were a child, you felt very comfortable with what you were assigned, or was it just not something that you thought about? That's one piece of it. Or was it once you were in adolescence that you became feeling more uncomfortable because genitalia were changing, your roles in society were meant to be different according to our societal rules? You know, what is it about that? And a lot of times they can't really pinpoint, except just telling me that they just felt something was off and they didn't know what it was. And I think that's becoming less of a problem because now there's so much access on YouTube, for example. There's so much more discussion about it in our society that people at least are considering it more often than they used to. Okay, but again, it's interesting to me. They just don't know what that feeling is, and so that gives them a real sense of anxiety, even though they don't sense a discomfort with their genitals or anything else. Okay, so I like this quote as well. Imagine you feel great about yourself, but when you look down, your body is the opposite sex from who you know yourself to be. Imagine what it would feel like to live with that discrepancy. I have not read that book, but that's one thing on my list. I'd really like to read that. And it's hard for me to imagine, but unless I'm talking with patients. And it's come to me, I've just seen it in a completely different light. So I really thank the patients who are so forthcoming in talking to me about how they feel about this. So maybe read it in your spare time. Okay, so incidence. Again, I think this data is old. I think it's limited. I think it's very, very much underreported. what they are saying in adults, 1 in 30,000 natal males, 1 in 100,000 natal females, and more recently of the total population, 0.7% of the total population. Okay? But again, I think it's very much underestimated. I have no idea what they're saying in Nevada, or I don't even think their data gathering is even close to being appropriate. So why does this happen is the big question. And to date, nobody really understands that, to my knowledge. So they've looked at a lot of different studies. Of course, most of these are very low numbers. So the first thing they thought was, okay, well, how about sex steroids in the in utero environment, and then once you're born, and how does that vary? You know, if you have a super high level of testosterone in puberty compared to the next guy, how does that change things? But basically, really, there's no difference in those levels of sex steroids between non-transgender patients and transgender patients. The in utero exposure to hormones also is not correlated, although what they did find was that their gender behavior, so maybe it was wider than what we typically think of as male or female behaviors, those are a little bit different. Sexual orientation, we know, is pretty well established, particularly in our patients with adrenal hyperplasia, female patients with adrenal hyperplasia. The incidence of homosexuality is significantly higher in those patients, presumably because of the bathing of the brain in androgens. But it's certainly not 100%, and it's not even correlated to the degree of virilization of genitals, which is also correlated to the level of androgens. So there's no really, really strong correlation. So it's also not correlated to what your external genitalia look like at birth, although that will help you with gender identification as opposed to dysphoria later on. Okay, so people with ambiguous genitalia, clitoromegaly, for example, in some of the disorders of androgens, that can be correlated. Understandably, if you have a very large clitoris, for example, and you're being told you're a female, that's going to cause some cause for concern and make you wonder, what should I be identifying as? So that makes sense to me. So in the disorders of sex differentiation, the chromosomes are out of keeping with the hormone levels in genitals, and the prevalence of gender dysphoria is higher than the general population, but certainly not 100%. So an XY female who's androgen deficient, so they have XY components though, raised as a female, there's a 40 to 60% rate of gender dysphoria. So pretty high, but again, not 100%, okay? So what is that? They're not making testosterone. Presumably they're responsive to estrogen. So much higher than the general population, but not even close to 100%. Klinefelter syndrome, this is not something that I see in my patients with Klinefelters. I've never had someone identify as having gender dysphoria, but in the general data, there's 6 times higher incidence of dysphoria than the general population. Now, the question I have is that really gender dysphoria, or is that dysphoria because their penis may be smaller, their testicles may be smaller, they have breast tissue, all because they have Klinefelter syndrome? So again, it's hard to read the literature and really understand how they ask these questions. Okay. So as I mentioned before, adrenal hyperplasia, the risk of gender dysphoria is about 5%. In those raised as females, which today, that's what everybody should be being raised as. But not that long ago, maybe 30 years or more, many of those were being raised as males, and plus minus in terms of treatment. And in those raised as males, the incidence was 12%. So the dysphoria is higher than the general population in adrenal hyperplasia, but does not correlate to degree of virilization, the level of androgens prenatally or postnatally, non-salt losers versus salt losers. Salt losers generally have a more severe form of that. So there's really no correlation with any of those. We do know that homosexuality, bisexuality is higher in those adrenal hyperplasia females than the general population. There's some really interesting studies that are happening now in looking at patients with gender dysphoria who then have gender-affirming hormones and what happens to their PET scans, and correlating those with natal males and females respectively. And interestingly, when you start giving them more of their gender-affirming hormones, the PET scans change to what is more typical of a natal male or female. So again, it's some very early data, but I find that fascinating that we actually can change, or we do change brain functioning in different parts of the brain light up. So interesting, needs more data. So genetics, we don't know of any genetic relationship at all. In identical twins, there's only a 39% concordance rate. Dizygotic twin pairs or fraternal twins, 0 concordance rate. I'm not sure that's not going. There we go, thanks. Okay, so in my patients, I see them, I guess, at different stages of social transitioning. And it seems that the younger you are, the easier it is to transition. It makes sense. You know, and I think what our society expects when you're a 6-year-old is much, much different than when you're 16. And so, you know, you can get away, particularly if you're a natal female, you can easily get away, I think, with wearing boys' clothes and being kind of a tomboy and so on. Okay, but that doesn't mean that you have gender dysphoria. That's just your preference. And maybe that's the way you play and that's who you hang out with and so on. Boys also, I think, can more easily socially transition nowadays as well, but it's more difficult for them. And how do you navigate that as a child? First of all, you clearly need your parents' support. And fortunately, the patients I see, most of the time, at least one of the parents is very supportive. Sometimes we have 2 parents, whether they live together or not, one is really at odds with the whole issue and is not supportive and doesn't want anything to be done. Had a daughter at birth and now says that's his son, and it's very difficult for them to manage. And I don't think there's a big difference that I can see consistently between moms and dads and how they view this. It's just very individualized, and I'd be interested to know of you who also take care of patients with gender dysphoria, if you see that as well. But it's really tough too if they're living separately and the guardianships and so on. You need to make sure everybody's on the same page before you start any kind of puberty blockers or gender affirming hormones. That can create a lot of problems if you don't. So again, I kind of see the gamut. So some of my patients who are as young as 6 and 7, they've already changed the birth certificate. They've changed their name, their gender, they've changed everything. And I'm actually a little reluctant when people do that because I don't think it gives them enough time to really consider that as they get older. For school purposes, I think, at least in Washoe County, the schools are very amenable to changing pronouns and names in use. Now, obviously on their legal documents, they can't change that, but most of the time the principals, nurses, teachers are pretty amenable to that. The problem lies when someone's socially transitioned and they have these different names and you get a substitute teacher in there, and that substitute doesn't know because all he or she has is the typical role. And so that can be very unmasking and revealing for a child who was thought to be X and then they say Y for the name. So that's a problem that we're still working on. It's getting easier to legally change things. Now it takes, for your birth certificate or other legal documents, it takes a note typically from a physician who's helping to treat that patient and the parent if they're under the age of 18. And then a whole lot of legwork and paperwork, and then voila, there you have your birth certificate. From there, you can get your driver's license, passport, and so on. So I encourage them, if they're going to do that, do the name change as well as the gender change at the same time. Just saves you some traffic. In adolescence, I've been pleasantly surprised at how well other students really support their transition. And I think this is just over time that it's happening, and kids are much more accepting now than they used to be. In some of the rural areas, I think it's much more difficult. There's fewer students, different ideals perhaps, and different ideas of what those social norms really should be. But in general, I think it's much more widely accepted nowadays. Some kids come in and say, hey, at school I'm this, and at home I'm that. And that makes for some discord as well, in many, many ways. So I actually enjoy talking to the adolescents who are natal males and transition to females, the things they learn how to do, and it just look fabulous. You know, the clothing, their makeup, their hair, it's really fantastic. And you can just see the confidence building in these patients as they transition socially. Typically the anxiety and depression, it doesn't go away usually, but it gets so much, much better once they're out. So binding is a big thing that many natal females are doing. So they wear literally binders, which are seemingly very, very uncomfortable. There's been some issues as of late in some of the medical literature that says maybe it's inhibiting or restricting cardiac output. So there are some concerns to be thinking about. Also in continually growing patients, adolescents who are wearing very tight binders, it may actually be impacting their ribs, their vertebrae, and causing some problems with that. So I think that's something we, as taking care of pediatric patients, we need to be very aware of, and making sure that when they're home, take the binders off. They're also extremely hot. I mean, imagine yourself in the 1800s wearing those god-awful girdles and those super tight dresses. It's like that, but on your chest, not just lower down. So it does make it hard to exercise. And if you have asthma or something else, you have all those other challenges. Tucking, you know, if you're a natal male and you've already gone through puberty, this is a big issue. If you wear a short skirt or tight shorts or something like that, you know, the last thing you want is to be revealed. So they have special underwear now that actually enables you to tuck the penis down. Then the problem is when you go to use the restroom, how do you untuck? But kids are managing actually quite well. Other people literally use duct tape to tuck themselves in. So some very uncomfortable things that these people go through. But so you know they are very committed to what their transitioning is.
A question real quick.
Yeah.
It says, can you change legal records without physical sex change?
Yes, if you mean, yes. So without doing gender affirming hormones, yes, you can. Okay, and especially in the pediatric population, that's quite easy. So what I say in my letters is that I know so-and-so, date of birth so-and-so, and I have been seeing him for gender dysphoria. He is in the process of transitioning, and we are monitoring his medical status. Okay, he may be on puberty blockers. They don't need to know that stuff. Okay, as long as we as healthcare providers are saying that we are doing the medical and social transitioning, and this is how he identifies, they need to respect that and do the change. Okay. That's a good question, very good question. It used to be that someone had to both socially transition as well as physically, and that used to mean actually very strictly that you had to have some surgical changes. And then it became only hormonal changes. And now it's just as long as you're under the care and management. Okay. That's my understanding anyway. So, you know, where I think it gets really hard for kids is PE, participating in sports. You know, which locker room do you go to and how do you navigate that? So a lot of times I'll have students go to the nurse's office to even change or even just to use the restroom. Or they'll wear their PE shorts and stuff underneath their regular clothing. They just don't want to change clothes, but they still want to participate. So it really runs the gamut, and from school to school. You know, I know there's policies that are supposed to be in place for whole school districts, but I can tell you on an individual school level, that's not what's happening. And there's some teachers who, of course, I'm only getting the one side from students who interact with certain teachers, but it can take only one teacher in a school to make it really, really miserable for patients with gender dysphoria. Public restrooms, you know, that is really a matter of how comfortable they are. I encourage them to do it as they're they're transitioning, and particularly if they've already modeled into the other clothing that makes more sense for them and that is more appropriate for them to be using the opposite restroom. But again, that's a big step, and especially if you're very young, it's a very big step, and which parent you're with and so on makes a difference. So the mental health issues, this is where I have my biggest concern, and I think that over the last couple of years, we've definitely had more mental health providers in our area who are trained and experienced and have the interest in taking care of young people with gender dysphoria or potential gender dysphoria. So, but this has been a big issue, and I think even currently, all of our mental health providers are jam-packed who have experience. So I'm always looking for people who are willing and able to help me manage patients. So I would say it's probably 25% of the time, by the time I see them in my endocrine clinic, have they actually met with a mental health provider. Only 25%. So, which means that most of these kids have come to this decision or understanding by themselves or with their friends or perhaps with their parents, okay? And so that's a lot of undiagnosed and untreated anxiety and depression, sadly. So, you know, where I think mental health providers are particularly necessary for what I do is to help me understand, okay, do you think that this is really the appropriate thing to do? I'm not asking you, is Johnny really Jane? That's not an appropriate question. I'm asking, is this an appropriate transition for me to help with? And maybe that's just limited to doing puberty blockers, okay? And then we wait a while and see which way that goes, okay? But the gender dysphoria aside, the anxiety, oppositional defiant disorder, all those things need to be addressed, okay? Because there's a high dropout rate, there's an extremely high rate of suicide or suicidal ideation at a minimum, probably 50% at least in adults. We don't really have that data so much in younger people, okay? So those really need to be addressed and treated. So additionally, you know, the parents need to be involved in the mental health assessment piece of that as well, because I need consent for the medical treatment ultimately. The chat groups online, I think those are great, although I have to say that I've never spent any time in those. And so as with anything online, you have to be a little bit careful with who constitutes those chat rooms. There's some schools that have support groups, mainly those that the teenagers have actually started themselves. Transgender Allies group is fantastic. You know, there's a lot to be offered, and more for younger patients, adolescents and children. And then the Hopes Clinic, of course, is great. They have a lot of support staff and support groups for patients with this as well. It's hard though. I mean, I can't tell you how often I encourage my patients to attend those. They don't want to do it. They're worried. Even if they've socially transitioned, even if they've hormonally transitioned, that's not something they really want to do. And so I try to get the parents to take them as well. So I've put up here the DSM-5 diagnostic criteria. I am not going to read through this, but please do. I think it's helpful, but it's certainly not all-encompassing in my mind, at least, with who really fits into this and at different ages as well. Okay, so we talked a little bit about the mental health support. Social support, of course, is very necessary as well. If your family is not supportive of you, it's not going to be an easy one. And again, if you can at least get one of your parents on board, I think it makes it go much better. As far as the hormonal support, so let's talk about that. So what I do is talk about puberty blockers. And so these are gonadotropin-releasing hormone agonists, so otherwise known as Lupron or Supprelin. And so these medications were initially made for kids with precocious puberty. So it's a very specific hormone blocker. It only blocks LHRH at the pituitary and hypothalamic level. So you're not shutting down growth hormone or thyroid hormone or anything else. They're very effective. They have very low side effects. They are very expensive and sometimes difficult to get covered by insurance, getting perhaps easier. So I use this as my first step Usually we allow them to go into at least a Tanner stage 2 before we will do that for the reasons I mentioned previously. Once in a while I've done it earlier if there's very significant dysphoria and other accompanying mental health problems. So what we see in a natal female is that within a month the menses stops completely. And that in and of itself can be huge in terms of the dysphoria. So I'd say at least half of the natal females will say that the dysphoria definitely gets worse right before a period and right during the period, and then it kind of gets a little bit better. The other half say, no, not really. It's more the breasts that really cause more dysphoria. So it's probably a little bit of both, and certainly the estrogen alone and the cycling nature of estrogen probably really impacts moods, anxiety, and so on. So I like to I call it a clean slate because it really helps the kids identify with what's happening there. So you got a clean slate from a hormonal standpoint. And then some kids just like to stay there on a clean slate, no testosterone, no estrogen. And I think that's very helpful for them to know that that's an okay option. You don't have to commit to anything more than that, okay? And this holds true for males too. So when we give the puberty blocker, the testosterone levels go down, usually acne gets better, muscle mass tends to diminish, which in some cases is really a sought after thing. They want to be a little softer. They want some hips. They want, not that hard body of muscle. And then if there is any hair growth, it may diminish a little bit, the facial hair, chest hair, those kinds of things. The other thing it's really, really helpful for is it minimizes erections, or should actually get rid of them entirely if you have no testosterone. So that's a huge thing if you're trying to tuck all the time. So it's very helpful. Some people have used Depo-Provera. I really don't think that's a good option. It may eliminate sort of your periods, but they're sort of haphazard at that point too. So I don't really like that as an alternative. Androgen blockers, estrogen blockers, those are used sometimes in cases where we can't get coverage of one of the GnRH blockers. I will use androgen or estrogen blockers. They just don't work quite as well. You have to take them at least once a day, if not 2 to 3 times a day. And then the last thing, some people will put kids on oral contraceptives, and maybe on a quarterly, like a seasonal basis. So they only have a period 4 times a year. But my problem with that is you're going to have probably a heavier period every 4 months or 3 months, and it doesn't get rid of the estrogen. Okay, so maybe you're not seeing the actual menstrual cycle as often, but you still have a lot of estrogen and all the impact and effects that estrogen has on us. So I'm not a big fan of that. Sometimes though, we don't get to do what we always want to do. And so in that case, I think the second line would be the androgen and estrogen blockers. Ultimately, I say I would like someone to be on puberty blockers for 6 to 12 months before we start on gender affirming treatment. Now, along with that though, is I need a letter by WPATH guidelines from a mental health provider that says, yes, we have we have identified that this patient has gender dysphoria. I think it's in her best interest that we now go towards gender affirming hormone therapy, okay? Because this is where I think it gets much more tricky. You're dealing with permanent effects. And what does that do to our brains, as we talked about earlier? It's not just the physical effects. That's what the adolescents really desire. But what I worry about is the long-term health effects and the long-term neurological effects on our brains and brain functioning. Okay? Whether good or bad, I think the jury's still out. So I need the confirmation from the mental health provider. I need support and permission from both legal parents if they are truly legal parents. If you're over 16, then we get informed consent as well. I have a whole list of all the potential side effects, short and long term. The biggest ones that we see short term would be liver enzymes going up, lipids increasing, purely from a medical standpoint. That's what we see. From a mental health, most of the time, I think that even with puberty blockers alone, let alone with testosterone and estrogen, the anxiety, depression almost always gets better, and significantly better. I've had One patient where we did puberty blockade and then started testosterone. In hindsight, really against my better judgment, but the mental health provider said, yes, I think this is the way to go. The mom was really adamant about doing it, and the child was more or less too. And things went downhill pretty quickly. And I think that patient already had such significant mental health problems that I don't know that we can really say it was testosterone. It probably didn't help, but I don't know that it actually hurt. And I mean, to the point that this person is literally a shut-in, doesn't go to school, doesn't work, won't come to doctor's visits. For a while, I was having phone conversations with him instead of in-person visits. And I had to just put the kibosh on that because it just wasn't a good situation. I see the question, if both are legal parents, can only one consent for treatment? The answer is you can, I would not, okay? And sometimes that creates problems. I was just meeting with someone yesterday for the first time, and they said, well, you know, dad is in the process of maybe giving up parental rights to this 15-year-old who's just now come out. And I said, I know this is difficult, but I need both parents because I don't want the dad being upset with mom and the child. And, you know, if there are ever any side effects from medications I give this person, I don't want there to be an issue with dad coming back and saying, I didn't support that, you know? So it's just not good all the way around, even if it means delaying treatment. I know that's really hard, and but I in fact, so I'm on a listserv through the WPATH organization, and so many people are taking care of adolescents, and this just came up. I just read it this morning, and they had started somebody on testosterone, and then the dad, who doesn't live with the mom and the kid, found out, and he was livid. And so now they're worried he's going to sue the doctor, and he's taking him to court to stop treatment, and all kinds of stuff. It's a huge can of worms, so I wouldn't do it. Okay. The follow-up with treatment, so I always get baseline labs, particularly lipids and LFTs, to make sure that we're doing okay. Every 3 to 6 months, we repeat height, weight, blood pressure, the Tanner staging. Usually the Tanner staging does not reverse, but hopefully it does not progress while on a puberty blocker alone. Obviously, if you're getting testosterone and estrogen, then that's a little bit different types of staging. Interestingly, even patients who have been cycling for even a couple of years, once they're started on testosterone, some of these kids are actually growing. They shouldn't be, based on what we know about normal puberty and physiology and growth plates, but some of them are actually gaining height. Some of the trans females are actually gaining a little bit of height too on estrogen. So it's kind of interesting, like to the tune of an inch or two. So pretty significant. Other labs, if they're on the puberty blockers, we look at LH, FSH, estradiol, testosterone, also vitamin D. I mean, a lot of these patients are not going outside for a number of reasons, so we want to make sure that we're replenishing them with that. The bone density issues, we don't really have a lot of good data on how often we should be doing this, but suffice it to say that you're still accruing bone mineral till about the age of 30. So if we're blocking puberty for any extended period of time, that's a huge concern. If you then put somebody on estrogen or testosterone, how does that change how you accrue? And then the bigger issue is, what normals do you use under DEXA? Because they're male or female. So there's a lot of issues associated with getting DEXA, but what I do is I look at the raw data. Are you still accruing? And is it at a fairly decent amount every 2 years or so when you're doing this? Last thing we want is people having osteoporosis at the age of 35 because of something that we did to them. Okay. The bone age, that's more to just say, do you have more time to grow or not? So it doesn't really change what you do so much. So for a trans female, I now use exclusively 17-beta estradiol, or Estrace is the brand name. I don't use Premarin. The dose I start with is usually 0.5 milligram per day. Keeping in mind, I have here that post-pubertal females can be increased more rapidly. the parents of these patients will not be happy with you. So I generally go very, very slowly. The other thing is if you have a very thin trans female and you start with high doses of estrogen, their chest is going to hurt a lot, okay? As those nipples get larger, as they actually develop breast tissue, it can be extremely painful, similar to a thin 10-year-old going through puberty. But most importantly, you know, those mental health issues and what mood changes are there, how significant are they? So I like to go very slowly and let them kind of adapt. Same thing holds true with,
Vitamin D index covered by insurance.
yeah, you know, the vitamin D labs, they'll generally cover. The vitamin D treatment, I just usually use over-the-counter stuff, so that's absolutely fine. Vitamin D3. For the DEXA, I've never had it be a problem to get it covered. So as far as I know, they're covering it fine. I don't know about the adult world, at what age they'll start doing it. Okay. If we say that a child is at risk for osteopenia, then usually they will cover that. Okay. So for testosterone, same basic idea. I start low, I go very slowly. Usually I start out with 25 or 50 milligrams IM Q month, but rapidly I have now been going to weekly sub-Q. It really depends on the families, how comfortable I feel with them doing it at home. Because remember, we're sending them home with a vial of testosterone, of 200 milligrams of testosterone. And I have concerns about that. It's a, you know, federally regulated substance. I don't want people just, bam, taking 200 milligrams. That's not a good thing to do. So you have to really be trusting your families to do the right thing. So these are kind of the labs I do. Hemoglobin hematocrit tends to go up fairly significantly actually with testosterone, the DEXA scans and so on. I won't belabor that. So I usually see with testosterone that people within 6 months will start to notice more muscular changes, maybe start to have some facial hair. It really depends on the dose that they're getting. Right around 100 milligrams a month or that equivalent is when I start to really see some better transition. Deepening of the voice, sometimes some clitoral enlargement. It takes usually a little bit more than 100 milligrams to do that. And then some breast atrophy. Now, you never get rid of breast tissue, but it may become softer. The actual Tanner staging usually doesn't change much. Okay? And estrogen, basically the same thing. Within 6 months, you start to see some nipple enlargement and so on. Decreased testicular size, increase in body fat, and so on. Oh, you know, sometimes people will ask me, well, why can't I just take testosterone? And that'll just shut down the cycles. That's pretty ineffective. And until you hit about 150 milligrams a month, which is a fairly good dose, you're not going to see cessation of menses on a regular basis. So I think it really, really throws the body off. And so I don't recommend doing that. I'd much rather do the puberty blockers first. Okay. So enlargement of the Adam's apple, deepening of the voice, those are irreversible. Erections will decrease. Of course, if you reverse it, then that's all going to come back. Okay. Fertility issues, this is a big one, and I think really tough for adolescents. When I ask most of my patients about having kids in the future, most of them say, well, either I don't want kids or I can just adopt. Like it's a really simple thing. And so clearly they're adolescents, they don't have the background to really understand this. So when I bring up cryopreservation, 99% of them say, oh no, absolutely not, I don't want to do that. And I think part of it is what you have to do in order to get sperm or eggs and the cost associated with that. But the thought of that is so dysphoric to them because it's confirming I have testicles, I have sperm, I'm going to save that, or eggs. So I think that's a piece of it too, and it's just not well thought out. I worry about that because, when they hit their mid-20s and 30s, I'm worried that they're going to want their own sperm or eggs. And by that time, if you've been on even puberty blockers, let alone testosterone and estrogen, your gonads are not going to be working well for you. It's been done, clearly it's been done, but it's much, much more difficult to get any viable sperm or eggs out at that point. Okay. All right, so real quickly, surgery. The kind of the trend now is to do top surgery before you go off to college, mainly because of the aftercare and they want parents involved. That's difficult to do for insurance reasons because many of them will dictate you have to be 18. So that's kind of a problem that we're having. And then getting somebody locally who will do that for the reasons that we're asking. Bottom surgery needs to be done at a center of excellence, no doubt about that, for males or females, in my opinion, okay? And the other things I think we talked about. You guys will have access to these slides so you can read these. I referred to most of these as well, okay? Here's the long-term issues, most of which we talked about. I do want to have just a few seconds for some questions too. Okay. Questions, anybody?
Hello?
Hello?
Did you say that these would be available to us after your presentation's over?
Yes.
Yes, so within the next week or so, we'll have them on our website. You can go look at previous clinics that we've had and go ahead and do them there.
Thank you very much.
Any other questions or maybe even, you know, support or experience that any of you have had that I didn't touch on?
I had a patient in Carson County who was interested. Family was supportive. They actually came with a sibling to be seen. We talked over the phone with the parents to make sure that it was okay. The school didn't know that this person was actually male by birth, but lived as a female for, I don't know, at least 4 or 5 years and was only, I think, 7th or 8th grade. So I don't think that they had insurance, so there was a limitation as to where I could refer them for. Number one, they had never had any kind of formal counseling regarding this. So that was my first thought was, you know, we really need to talk about this before we do anything physically or like medication wise. So I ended up actually referring them to Children's Hospital of Oakland, and they never followed up, which just makes me really sad because I just feel like they were desiring transition. This person was desiring to not only live as a female, but physically be a female, and yet just was lost to follow up because it was scary. It was, I'm not really sure or what I could have done differently to encourage this patient.
Yeah, that's tough. And, you know, I think it's hard for people to go outside of our community sometimes for any medical problem. It's just so big out there. And then all the other issues. You know, I think probably Hope's Clinic, and Natalie can speak more to that too, but Hope's Clinic could be helpful, and certainly I'm willing to see them. You know, I can talk to the powers that be and make the situation known that there's no insurance, and I think we can work around that. The harder part is getting medication coverage, especially for the puberty blockers. But it sounds like now is the time, because my guess would be that puberty is already happening or about to happen.
Yeah, almost happening. Yeah, probably. Yeah. I mean, close.
Mm-hmm. Yeah. So let me know if I can help with that.
Thank you.
Sure.
Do you want me to answer that question a little bit?
Yeah. Yes, please.
Hi, so I'm Natalie Vogel from Hope's Clinic, or Northern Nevada Hope's. So we have a nurse practitioner here who does provide a lot of the same medical care as Dr. Eckert, but she does not see people under the age of 18. So what we do provide is a whole lot of primary care for people who don't have insurance. And based on the story that you're telling, you know, that's a person that we could easily see here, just as you did. And then we would try to get them into one of the programs like access to healthcare or something else. So that's the one that comes to mind. Get them on Medicaid if they qualify, so that they could then go see Dr. Eckert in the case of a child. When it's an adult, we provide pretty full service care here, except for the surgical pieces, but we have places we send them to, just to answer that question.
Thank you. I think I feel like we're shutting them down. We're like, oh, sorry, you're not of age. We can't give you any help. And that is really hard for me to say, sorry, like you're not old enough to make this decision. I mean, whether you're on board or not, I think that I just feel bad saying, sorry, I can't do anything for you until you have more resources or you're a certain age. And that's what I feel like I have to say.
Yeah.
And I think we have that challenge, not just for this particular issue, and Dr. Eckert spoke about this, when we don't have at least one parent buying into this whole conversation that will get them to the mental health provider or is willing to follow through, because a lot of these steps are really challenging. We do feel like our hands are tied. And that's not just true about gender dysphoria. We could say that for a lot of things, right? But when we don't have the buy-in from the guardian, we have some options available, certainly, but it's absolutely limited. I completely agree with you.
Any other questions? Comments? Well, thank you all for joining us. And like I said, part 2 will be in September as well, with a little bit different take on things too, and the medical issues surrounding that. Okay, so I hope you'll join us for that.
And then also on Friday, August 3rd at 12 o'clock, we're going to have another Pediatrics Echo on preventing lead exposure in children. So if you guys want to go ahead and put that on your calendar, we'll see you then.
Thank you.
Thank you, guys.
Thank you. Bye.
Bye, Natalie.